female infertility. So that would be the sequence of the talk. So let's start with the first Okay, so sorry for that. That was when we were trying the PPT, the slides were moved. So you see the latest WHO manual for semen has come in 2020. That is after a gap of almost 10, 11 years, because the last version was in 2010. So what are the changes over the years which have happened in so-called normal reference ranges as per WHO? So you will see that in volume, the change is not significant. The volume has changed from 2 ml to currently 1.5, 1.4 ml. The sperm concentration, which is minimum sperm concentration, there is no major change. It's 20 million earlier, and now it is 16 million per ml. Total sperm count was 40. It has remained more or less the same over the years. Motility, earlier we used to say minimum required was 50. Now it is reduced to 28 and 30%. The most significant change is the normal sperms. Now this figure of 54 is wrong in 2020. It's 4. That is a mistake. So the normal forms which were minimum 50% are now minimum 4%. So this is a major change. In other words, we are saying in a normal semen analysis, up to 96% of the sperms can be abnormal sperms. Now, why it is so, I will discuss when the time comes. Is it because the way we scored has changed, or because of environmental exposure, we are having more abnormal sperms than before, or it's a combination of both? Then viability, now we say, is this 54 and 4 got interchanged in the last this thing. The viability is 54%, and as you can see, it has remained. Earlier it was minimum 75%, and now it has come down to 55%. Now, what do you mean by motility and viability? See, there could be viability will be always more than motility, because there could be some non-motile sperms which are still alive and not dead. So suppose your motility percentage is 40, your viability cannot be 35. It has to be 48 or 50. This is just to tell you what is the difference. So viability would include non-motile live sperms, which are not included in motility section.
Now, Avinash, for a long time we couldn't see your screen. It was now it's again the screen is now it's back again. Now it's back again.
Can you see this screen now?
Yes, yes.
Okay.
Now,
So
Once, sir, sorry to interrupt, sir. Could you switch on your video? The participants wants to see you as well while you're presenting.
Okay, fine.
has gone, Avinash.
Yeah, I'm just settling it.
Okay. Avinash, I think you're frozen.
Okay, just give me a moment.
Sure.
So any problem, sir? I think sir is frozen now. Yes, sir.
Hello, hello.
Yes, sir, we can hear you, sir.
Mona and the hell, I think he's got some. I just got him on the phone. There is a glitch over there, and his IT person is helping out.
Okay.
In the meanwhile, either Mona or Tehel, can you put up a poll question over there in the chat box? Ask the participants how many people think that infertility is an important subject for MD in pathology. Just put it up and let's see what people say in the chat box. Yeah, Vinash. Huh. Yeah, you are a co-host. You are admitted, but I'll ask Ruchi to do it
Yes.
again. Okay? All right. Okay. Thank you. Bye. Ruchi,
Yes, ma'am.
he says that they have connected him with another device. So can
Okay.
you make him a co-host again?
Course. Okay, now.
So some people, there, Avinash is back.
Yes, yes. Sir, you are muted. Sir, please unmute.
Now, can you hear me well?
Yes, yes, we can hear you, sir.
Now we'll just start sharing the
Yes.
presentation. दाबायचं काय ते?
Full screen. Just make it full screen.
काय
Very
दाबायचं?
good. It's now fine.
Yes.
It's now fine, na?
Yeah,
Yes, sir.
absolutely. And in the meantime,
Yeah.
Avinash, I asked them to answer a question. Is this infertility topic important for MD pathology students? And we have some answers, and it said somebody has said it's very important. It came in my MD exam. So
No, it is important nowadays because see, just look at it this way, about 25% of the couples are now infertile and are seeking help from IVF centers. So it has become a common investigation now. Not only semen, but anything, as you know, PCOS instances from 10% earlier is now almost 20-25%. So it is important, I guess.
very good. Okay, Avinash. Sorry, we.
Okay. So now this semen examination, so I can read it, yeah. See, one thing you must know the limitations of semen examination. When we talk about semen examination, the WHO has done studies in multiple countries and they have arrived at a normality range which is the 5th percentile, which was the minimum required for achieving conception. That's how it was. So what it tells you about the fertility potential in a given couple. But if you ask me what is the predictive value of semen analysis, suppose considering the female partner is absolutely normal, let's presume the ovulation is absolutely fine and the tubal patency is absolutely normal. Can a normal semen analysis assure pregnancy outcome? So the predictive value is not more than 40-50%. So why is it so? If the female partner is absolutely normal and your semen report is normal, why it is that the predictive value is so low? Because what semen tells you is about the number of sperms, their motility. What it doesn't tell you, the ability of this spermatozoa to penetrate into egg and the ability of spermatozoa to transfer the genetic material, achieve conception, and also about implantation. So these factors are not outlined in semen analysis. So there are some sperm function assays which try to address that gap, which I will be discussing later. So count and motility and morphology is what we learn from semen analysis. Now, any workup of infertility, of course, starts with physical examination. This is very important. So I will tell you the reason. If in history the patient says there was a history of abortion, then the fertilizing ability of the sperm is proven. You don't need sperm function assays. You don't need any major testing. Your testing is why the patient is not conceiving again. But you know that the sperms are capable of fertilization. If there are history of repeated miscarriage, then you are going to do something called as sperm DNA fragmentation test. So which is totally different from being infertile because there are repeated pregnancy losses. A general examination is important because if the testicular size is so small, then you know that this patient is unlikely to have a good sperm count no matter what medical management you do. Also for detection of varicocele, it is very important to do a physical examination. Now this we have said that apart from semen analysis, we judge sperm viability. It's one of the criteria in WHO. There are sperm function tests, then there is semen culture, there is detection of anti-sperm antibodies, there is something called as postcoital test, various hormonal assays, testicular biopsy and sperm function assays. We will not be discussing everything in detail, but I will tell you the importance of each one. Now, this I have already shared with you that the semen analysis is only 60% accurate in predicting infertility. Many men with poor quality semen, if the female partner is normal in the first few years of conception, would father a child. The duration of infertility is very important. Suppose a patient comes to you with 10 million sperm count, 30% motility, but married for only 1 year, his trying time is not over. Vis-a-vis a patient who has a 50 million count, 50% motility, wife normal, but he has tried for 5 years, then we will go aggressively to a patient who has normal count motility, but the duration is 5 years. So that means the duration of infertility itself becomes a prognostic factor outweighing the sperm count, because that means there is a sperm functional defect, otherwise there would have had conception. While the trying time is not over for a person who is having 10 million count and 30% motility, because it's only first year of the marriage. Various terms used. Normospermia is something where all semen parameters are normal. Oligospermia is low sperm count. Asthenospermia is sperms with poor motility. Teratozospermia is sperm with multiple morphological defects in a single sperm. Azoospermia is there is semen volume. Fructose is positive, but there are no sperm. So suppose a patient undergoes vasectomy, he will not have any sperms, but he will have ejaculate. His ejaculate will be normal because beyond seminal vesicle, there is no obstruction. So in that case, he will have normal semen volume, fructose will be positive, but there will not be sperms. So that we use the term azoospermia. When you use the term aspermia, that means there is no ejaculate. And when there is no ejaculate, what are the possibilities? There are 4 possibilities. One, ejaculatory duct obstruction. In our country, because of seminal vesicle, TB, or past sexually transmitted diseases, the ejaculatory duct can get obstructed. Secondly, the patient can have retrograde ejaculation. Some diabetic patients have retrograde ejaculation, so they don't ejaculate forward. Thirdly, the patient can have a partial ejaculate. And fourthly, there will be congenital absence of vas, and usually congenital absence of vas is also concomitant congenital absence of seminal vesicle. So there are no seminal vesicles to produce ejaculate. So whenever there is aspermia, remember the volume will be low, the pH will be acidic, and semen fructose will be always negative. These are various grades. Now WHO classifies as A, B, C, D. A is excellent, B is good, C is moderate, and D is non-motile sperm. This is semen diluting fluid. Essentially, it's a sodium bicarbonate with some drops of formalin to immobilize the sperm so that you can count. But if you are using Mechler's chamber and not Newborn's chamber, then you are counting the motile sperms and you are not trying to count immotile sperms. Then we don't use semen diluting fluid. So whenever we are using semen counts in millions per ml, you can directly see in Mechler's chamber. But WHO still recommend Newborn's chamber because it is more accurate compared to Mechler's chamber, and you have to count immobile sperms, which you can then do better than counting motile sperms. So these are the various methods you have. As I have mentioned to you, a 10 micron deep is the depth of our conventional Newborn's chamber, and you can use immobilized sperms, and you can also use something called as a Mechler's chamber. Now, when we come to fructose, fructose is a sugar which is unique to human beings, and it is measured by a test called Seligmanov test. So we take 0.5 ml of semen and 5 ml of Seligmanov's reagent, and it gives a pink color. But always remember that this reagent goes bad on standing. So you must use a control. Otherwise, your old Selingmanoff's reagent, if you use, it gives a false pink color in absence of fructose. Now I will give you, on the basis of our discussion, I will show you a report. It's a 30-year-old male with a history of infertility. His semen volume is very low, 0.3. He has no sperms. His pH is 6. Normal semen is alkaline 7.5 or 7.7. His pH is 6 and fructose is negative. So the possibilities are what? The possibilities are, which I have already discussed with you: incomplete semen discharge, ejaculatory duct obstruction, congenital absence of vas. Because congenital absence of vas, the Wolffian duct derivative, vas and seminal vesicle have a common embryological origin. So if vas is absent, usually seminal vesicle is also absent. So it leads to negative fructose. And the wrong answer is a vasectomy or a obstruction at the level of epididymis. By vasectomy, there is semen which is still produced in seminal vesicle, fructose is still produced, and semen volume is still normal, only there are no sperms. Now, it is important to differentiate between other cells in semen and pus cells. Why? Suppose somebody has azoospermia, no sperms. But if I see spermatids or spermatocytes or spermatogonia, then we have ruled out any kind of obstruction. We have ruled out obstruction at the level of testes and epididymis, or even at the level of ejaculatory duct, because you are seeing testicular cells in the semen. So we know this is not a case of obstruction. Also, sometimes you mistake these immature cells for pus cells. Now the normal WBC percentage in semen is less than 1 million per ml, and normal spermatids are less than 5 million per ml. Now if WBCs are more, then it produces a lot of reactive oxygen species and sperms become immobilized. And don't equate pus cells in the semen with pus cells in the urine. See, pus cell in the semen is an uncentrifuged sample, and if you see 1 to 2, that is also high. If you see 1 to 2 pus cells in the urine, it is considered normal. That is because we are taking 10 ml of urine, doing centrifugation, and then we are examining. Semen, we are not doing centrifugation. So even 1 or 2 pus cell becomes significant. And as I have mentioned to you, they produce lot of reactive oxygen species and cause immotile sperms. So then the question comes, if we are saying in today's context that only 4% of the sperms are normal, is considered as normal, then usually majority is considered as normality. In other words, if we do a bell-shaped curve as everybody's blood sugar who is participating in this seminar, we will say that 70 to 100 is normal fasting sugar, because that is where majority of you are falling. Then 100 to 126 we will say is a pre-diabetic, and anybody above 126 will say diabetic. So usually normality range is wider. So how do we know in semen that this 4% sperm is a normal range and not 96%, which we are calling abnormal? So the answer to that is, there is a reference population of spermatozoa which is taken as a reference population, where we obtain the semen after coitus from the internal os in the cervix, because the cervix has natural mechanism, the cervical mucus has natural mechanism of filtering all abnormal sperms and allowing only the normal ones to go inside. So if I obtain semen sample after coitus from the level of internal os and do a pap smear, I will see majority of the normal sperms. And that is our definition of normality. So what is the definition of normality? They should ideally have 3 to 5 micron length, 2 to 3 micron width. The acrosomal area should be between 30 to 70%, and there should not, the tail is approximately 14 microns, and there should not be any significant morphological abnormalities. Now this is to show you such a normal sperms. Now this I have discussed about pus cell in the semen. These are genuine pus cells. You will see that there is nuclear bridging and the outline is not regular and round, but it is serrated outline. So these are pus cells in the semen. You can identify sperm morphology and other cells in the semen by either phase contrast. Commonest method is papinocolor, but you can use any stain. Jimsa stain, Shore stain, HNE stain. I will show you some of the examples. So there is something called as multiple anomaly index. That means how many abnormalities are there in each single sperm. Now I will show you example. The maximum number of abnormalities can be head, midpiece, tail, and the neck. Everything abnormal. The maximum number of abnormalities in a sperm can be 4. Now you look at the correlation between morphology and the pregnancy outcome. By strict criteria, if there are more than 15% normal sperm, the pregnancy rates are 82%, and they fall down to very poor, less than 4%, the pregnancy rates drop down significantly. Now this is purposely to show you a single sperm with multiple abnormality. So you will see that here there are 3 heads, there is no midpiece, the tail is deformed. So the number of abnormalities are more than 3 because the sperm which are there are also not normal sperm. One has no acrosome. So a single sperm having so many abnormalities. Then we come to sperm viability. I mentioned to you, if a semen sample comes to you with all non-motile sperms, then the gynecologist wants to know that these sperms are dead or alive. Because if there are few alive sperms, he can do what we call as intracytoplasmic sperm injection to achieve pregnancy. So then we do a viability test with eosin nigrosin test. This is how a viable sperm would look like. Now this is a supravital stain. So if the sperm takes eosin, that means the sperm membrane is not intact and it's a dead sperm. So this is a test which is showing you white sperms which are viable sperms. These are the sperms which are dead sperms which get stained pink in eosin nigrosin. So this is to judge the viability. Nowadays, in our lab, we do viability by flow cytometry. This is another case just to ask you. This is a patient with apparently normal count 40 million, reasonably good motility. The progressive motility is 25%, then non-progressive is 20%. But the sperm morphology shows that 94% of the sperm are round-headed. They are without acrosomes. So this is a condition which is called as globosospermia. And since the sperms have no acrosomes, these patients, in spite of normal count and motility, cannot achieve normal pregnancy or even with IUI. And even with ICSI, pregnancy outcomes in these cases are poor. This is to show you one case which is what we call as globosospermia or round-headed sperms. You will notice that the count and tails are absolutely okay, but the sperm heads are all round and there is complete lack of acrosomal cap. There is no acrosomal cap developed. So these sperms cannot have acrosomal enzyme release to penetrate the zona pellucida, and these patients cannot achieve normal pregnancy. This is to show you tail abnormalities. So these sperms not only have poor acrosomes, they have short tails. And you will have many patients who have 80-90% short tails. So natural pregnancy in such cases is very difficult. These are sperms which to a naked eye would appear normal. But if you look at it, then the sperms have very small acrosomes. So earlier we would classify these sperms as normal because their length is 3 to 5 micron, breadth is 2 to 3, the tail is 14 micron. But if you look at the acrosome, most of them are not having 30 to 70% acrosomal area. Only one sperm is having 30 to 70%. The rest are having 10 to 20% acrosomal area. So by today's criteria, these would be classified as abnormal sperm, and that's the reason, because we are scoring so strictly, that anything more than 4% as per WHO is now considered as a normal range for the number of normal sperms morphologically. This test is, I will just discuss briefly. If an immotile sperm is exposed to fructose solution, hypoosmotic, and the sperm is actually alive, it undergoes a tail curling. And this tail curling tells us that though this sperm is non-motile, this sperm is still alive. You will see they have formed a, if you see the second side, number 2 is showing a tail coiling. Now this tail coiling means this sperm, though it is non-motile, it is alive. Similarly, the 4 number sperm is showing tail coiling. So at the time of actually doing ICSI, at the time of the embryologist selecting the viable sperms out of non-motile sperms, they cannot stain it with eosin nigrosin. So they will expose the sperms to hypoosmotic solution, and the sperm showing tail curling are then chosen for the purpose of ICSI because they are the live sperms. So that's the function of this particular test. Now, what is the importance of hormonal assays? Now, I will just give you an example. A sperm count is 2.3 million, so very low. But FSH is normal, LH is normal, testosterone is normal. So, does it mean that people with normal FSH, LH, testosterone necessarily have normal sperm count or normal testicular function? No, the answer is no. In majority of oligospermic patient, your FSH, LH, testosterone will be normal. They won't help you. But where it helps you, I will show you. If the FSH is high, very high, more than 2 times the normal, and testosterone is very low, it will always mean that the testicular function is abnormal. For example, if your FSH is 20 and testosterone is 110, then this person will always have very low sperm count or poor sperm count. But a normal FSH, LH and testosterone cannot assure a normal sperm count. Now, testicular biopsies day by day is getting limited in cases of obstructive azoospermia or those cases of oligospermia where we want to see whether any testicular sperms can be used for fertilization, or those cases of azoospermia where the donor, the patient is willing for testicular sperm extraction. Now remember, the testicular sperm fertilization rates are very good compared to seminal sperm because these sperms are not exposed to reactive estrogen species and don't undergo a transit time of 120 days from testis to semen. So even in azoospermic, if you are able to identify occasional sperm on testicular biopsy, by squeezing, this occasional sperm can be retrieved by TISA and then they can achieve a pregnancy. So in case of non-obstructive azoospermia, that means the testicular function is, we are looking at a patient with small size testes, markedly raised FSH/LH, testosterone is very low, epididymis is not turgid, the semen doesn't show sperms, but it shows fructose positive and a normal semen volume, then we know that this is a case of non-obstructive azoospermia. You then would do a testicular biopsy only if the patient is willing to undergo testicular sperm extraction and ICSI. Otherwise, you don't submit them to testicular biopsy. We don't do testicular biopsies in oligospermics anymore. So it's either obstructive or non-obstructive azoospermia. Sometimes they do a fine needle aspiration biopsy, which shows 85% correlation with a testicular biopsy, which is conventional. Now, conventional testicular biopsy must be about 4 to 5 millimeter in size, should show at least 80 to 100 seminiferous tubules, and must be always collected in Boyne's fluid. It should never be collected in formalin, because formalin causes severe distortion of the seminiferous tubules. There is exfoliation of all the spermatogonia, spermatocytes and sperms in the lumen. Everything gets clumped together and you cannot identify sequential maturation of sperms, or whether this is normal biopsy or not if it is preserved in formalin. So please insist that the sperm, for the assessment of testicular biopsy, it should be always collected in Boyne's fluid. This is just to show you how a normal spermatogenesis looks like. We'll go to higher power. You will see that the seminiferous tubules cell wall is very thin. There is sequential maturation from spermatogonia to primary spermatocytes, and when you come to lumen, they are lymphocyte-like dense cells which are spermatids, and in the central portion you will see oval-shaped spermatozoa. So this is showing normal spermatogenesis. This is a slide which shows you severe atrophy. This is a case of Klinefelter, so not even Sertoli cells are present. All tubules are hyalinized, so complete testicular atrophy. This is what you will see, where you are seeing spermatogonia and few primary spermatocytes, but unlike the previous slide, you are not seeing any spermatids or mature spermatozoa. So you will call this as a maturation arrest at the level of primary spermatocytes. This is to show you it's not normal, but you are seeing some spermatozoa. So you are seeing primary spermatocytes, and in one of the tubules you are showing some spermatozoa. So this is a case of a partial maturation arrest or a hypospermatogenesis, and these sperms are sufficient to obtain pregnancy by ICSI. This is again to show you a Sertoli cell only syndrome. So here you are seeing that the tubules are small, they show thick baseband membrane. There are apparent Leydig cells which are slightly hyperplastic, and the seminiferous tubules are lined by a single layer of Sertoli cell and nothing else. This is the high power view to show you only Sertoli cells and no subsequent maturation. So the conclusion is that the testicular biopsy is in today's times is mainly done in cases of azoospermia, both obstructive and non-obstructive. In cases of obstructive azoospermia, if the testicular biopsy is normal, they can do what is called as a vasoepididymal anastomosis to remove the obstruction, or they can take epididymal sperms and use it for ICSI or deep freeze it and then use it for subsequent IVF cycle. In cases of non-obstructive azoospermia, those patients who are willing to undergo ICSI, you want to know whether the testicular tissue contains an occasional sperm, and if there is occasional sperm, that can be retrieved by procedures like TISA, and then it can be used for ICSI, and with surprisingly good results. If you are able to get sperm in TISA by testicular sperm extraction, the fertilization rates are as high as 30 to 40%. So we discussed that the sperm count and motility alone is not predictive of outcome as far as pregnancy goes. So we know there are some additional tests. Most important is sperm DNA fragmentation test. So if the sperm DNA fragmentation normally should be less than 15%, if it is higher than 15%, then it's subfertile, and if it is higher than 30%, natural pregnancy is very unlikely, and these are patients who undergo repeated abortions. Then there is a test called mitochondrial membrane potential, which tells us about number of depolarized sperm, and they should be higher than 63%. If the MMP is lower than 63-64%, it is considered as abnormal. This is just to show you flow cytometry based evaluation of MMP. This is to show you sperm DNA fragmentation, how it looks on flow cytometry based assays. And this will be a typical report of sperm DNA fragmentation. If it is less than 15%, we call it good fertility potential. If it is between 15 to 25%, we call it fair fertility potential. If it is 25 to 50%, it is poor fertility potential. And if it is more than 50, this patient can never conceive naturally and is likely to have multiple abortions. So this test is a commonly used test for assessment of sperm function. MMP is not so commonly used, but all IVF clinics and urologists would use DNA fragmentation for assessing the fertilizing potential as well as for knowing in cases of multiple abortion whether there is increased incidence of DNA fragmentation. And many patients with varicocele surgery or antioxidant therapy or giving coenzyme Q10 and vitamin E, their DNA fragmentation can be lowered. So it's not that it's irreversible. Some medical management exists to reverse it before the lady tries again. Now we come to female investigation. Now we all know that when we talk about polycystic ovarian syndrome in today's world, it's not a gynecological problem. The female goes to gynecologist because her presentation is either hirsutism, acne or irregular period. But it's a metabolic syndrome. It's a pre-diabetic state. It's a state of insulin resistance. So these patients will have following abnormalities. They will have altered FSH-LH ratio. That means FSH is on the lower side, the LH is on the higher side. Prolactin is borderline high. They will always have androgen excess. They will have higher insulin values. They may have higher prolactin and DHEA sulfate values, and they will always have impaired glucose tolerance and state of insulin resistance. And the incidence of diabetes going forward is very high in cases of PCOS. There are some cases of 60 to 70% of PCOS are obese. But in India, about 25 to 30% of PCOS are lean PCOS. So where weight is not there. So this is the typical presentation. PCOS is a clinical syndrome. There is no single test which diagnoses. The blood parameters are helpful, but essentially the patient would have androgen excess, insulin resistance, and the AMH is increased in cases of PCOS because of the number of Graafian follicles are increased. So I have already shared with you that FSH is low normal, LH will be elevated. The FSH-LH ratio is altered. So LH is usually more than 2 times the FSH. On ultrasound, these people will have polycystic ovaries, estrogens will be low, and androstenedione or DHEA sulfate may be elevated. So there is no single test, but it's a cluster of tests and a clinical presentation which makes a diagnosis of PCOS. I have also told you about lean PCOS and obese PCOS. Lean PCOS are more difficult to treat because weight loss alone doesn't reverse their state of insulin resistance. There is strong association of PCOS with thyroid disorders, with Cushing syndrome, with hyperprolactinemia, with adrenal disorders, and there are increased levels of IGF-1 in some of them. So there are associated conditions which are associated with PCOS, which we need to rule out. The metabolic abnormalities are typically like metabolic syndrome. So you will have patients with high cholesterol, high triglyceride, high fasting insulin, high postprandial insulin, the HOMA index is abnormal, the glyco-HB can be in IGT level, that means around 6 or 6.2. So these patients are in a state of insulin resistance. So usually the test is performed for PCOS on day 3 of the menstrual cycle. These people have irregular cycles, so you don't induce their periods by progestogen. Wait for their bleeding to occur, and on day 3 you estimate all the hormones. Then I would like to talk something about anti-Mullerian hormone. Now anti-Mullerian hormone is becoming a very important test to tell us something about ovarian reserve. So many people think it's a test for fertilizing ability. It is not test for fertilizing ability. It tells you about the ovarian reserve, and in many patients today, we are seeing at the age of 35, the anti-Mullerian hormone level drops to 0.3, 0.4. It's very poor. So in these cases, this working woman, we retrieve the eggs and do egg embryo freezing or egg freezing for future pregnancies, because the incidence of premature ovarian failure is increasing for unknown reason. And many patients with polycystic ovarian disease will have a higher value of AMH. That doesn't mean they have better fertilizing potential. It is because they have more follicles to produce AMH. So remember, AMH is not a test for fertilizing ability. AMH is a test which tells us about what is the ovarian reserve left in a given female partner. So if AMH is low, we will be very aggressive and will straightway do IVF or ICSI, because we don't want to waste her eggs by doing IUI or wait indefinitely for natural cycles. So this is and normal AMH report. The optimal level is between 4 to 6. The satisfactory level is between 2.2 to 4. A low fertility is between 0.3 to 2. And surprisingly, you will see many young girls which are falling between 0.3 to 2 today. And there are, I would say, at least 20 to 30% of young girls will fall in the range of 0.3 to 2.2. You must do AMH by approved technologies, because different machines give you different results. So there are fetal medicine approved machines or instrumentations like Roche or Alinity, or there is an instrument from Beckman which are approved for estimation of AMH, so the values can be detected reliably. ELISA assays are not very reliable for AMH evaluation. So lastly, we come to recurrent abortion testing. All of you know that we will do torch assays, karyotype, and variety of other tests, mainly cytogenetic evaluation for female partner. So we have tried to briefly cover semen analysis, importance of sperm morphology, importance of sperm function test, importance of sperm DNA fragmentation assays, testicular biopsy to be done in cases of only azoospermia, obstructive if the patient is then subjected to vasoepididymal anastomosis, or aspiration from epididymal sperms, or non-obstructive azoospermia if the patient is willing for ICSI, then retrieval of testicular sperm for ICSI, and something about female infertility, commonest presentations of PCOS, and something about anti-Mullerian hormone. And then I will be happy to answer any questions if any.
Thank you, sir. Thank you so much for your wonderful lecture. There is one question from the audience regarding the male age-related syndromes for infertility. Sir, am I audible?
Yeah. You please go ahead with your question.
Yes, so the question is about the male, so Dr. Swati Dahe wants to know about the male age-related syndromes for infertility.
I didn't get the question. Age-related means, does he want to know whether the sperm count deteriorates with age? The answer is yes.
Means they want to know about related syndromes for infertility.
So male-related syndromes are the genetically inherited conditions like Klinefelters, or you have a short Y microsomal deletion, but most of the oligospermic individuals are cytogenetically normal. So the assessment is essentially done by semen analysis and not by cytogenetics. So it's a clinical examination, evaluation of semen, which would determine. We will suspect Klinefelters only if the testes are very small, there is total absence of facial hair, and then we will do whether it is XXY. In cases of oligospermia, typically these patients don't undergo cytogenetic evaluation.
I think that was asked by Swati Dahe. Swati, please type in the chat box if you have something specific that you want to ask. Okay. There was another question, I think. Lots of people, Avinash, are wanting some of the slides to be shown again. Now, for those people, I will say that this presentation will be on for 48 hours. So you can access that at any time and see the slides that Dr. Fatke has already shown. So I don't think that, we can show the slides all over again. Okay, there is another question. You'd want to, Mona, you want to ask? It's from Amit
Yes,
Gharia.
yes, ma'am. Dr. Amit Garia wants to know how to differentiate round cells on morphology.
Pardon?
How to differentiate round cells from pus cells on morphology.
Yeah, so that's a very good question, because we commonly see these getting confused, and people come with a semen report showing plenty of pus cell, and when I see the semen, it's actually all spermatid and there are no pus cell. So the only way to differentiate is actually do a morphological staining by either pap smear or Shore stain. And spermatids, you will see the outline is perfectly round, their nuclei are round, and there is no nuclear bridging. So it's very easy to identify once you have stained it. In a unstained, the size is very similar. So you can easily mistake spermatid for pus cell. So the answer to that is, if you just stain it with pap smear or H&E, you can easily differentiate the two. By the round configuration of spermatid, the nucleus, if at all, is also round and they are not bridged together, while the configuration of pus cell is not perfectly round and there is nuclear bridging. And then, of course, the granularity of cytoplasm also helps. But if, in addition, if somebody wants, there is a specific test called peroxidase test to differentiate between pus cells which are peroxidase positive and spermatids which are peroxidase negative. That is, if you are dealing with the live sample, but the easiest way is to stain them with pap smear or H&E.
Thank you, sir. There is another question from one of the participants is about the best method for semen analysis on OPD basis.
I would say, those who are even undergone little training, immobilized sperm, the easiest way is if you take a WBC pipette and if you try to aspirate sperm, sperm is a viscous material. So you cannot do your dilutions like how you do for blood. Blood uses uniform viscosity, means blood is a fluid which will get proportionately aspirated. For semen, you need a large bore pipette where you will take 50 microns of semen in a small test tube and add a corresponding amount of sperm diluting fluid, and from that you will charge your Newbor's chamber. So most important step is aspirating that 50 micron semen with a positive displacement pipette. So you will have to actually aspirate 50, and suppose you want 1 in 10 dilution, then the remaining 4.5 you can add diluting fluid. And then from that you will take a drop to charge your
Thank you, sir.
Newbor's chamber. The problem comes where they try to do WBC type of dilution with a WBC pipette, because that doesn't go correct. because the semen is very viscous material and the sperms are not uniformly distributed across the semen. Some parts are liquefied, some are unliquefied. The other method is post liquefaction. You can just take a drop of semen and put it in Mechler's chamber and you count the number of sperms in the grid. And suppose there are 12 motile sperms, then the count is directly 12 million. So it directly gives you count in millions per ml. So that's for those who are not trained, this is very easy. But the problem I will tell you, the Mechler's chamber cost is about 35,000. And if I have 20 or 30 or 40 semen sample, then I cannot use the same Mechler's chamber. So I will need to clean it each time thoroughly and go to the next. So a Newborn chamber, you can use 20 at a time and go on washing them sequentially if you have more semen samples. But if you are going to have one or two semen samples, you can easily use a Mechler's chamber because it is easier to use.
Okay, thank you, sir. Another question is about the role of endometrial biopsy in infertility.
Role of?
Endometrial biopsy in infertility.
Now we are doing it when I started my practice, even for day of ovulation, we were doing, endometrial biopsies. There was nothing like follicular studies or ultrasound. We used to do serum progesterone assay on day 21. And then there were scores and the days where, you will see older textbook showing subnuclear vaccination, that is day 1, day 2. But that is not done anymore. So unless you are suspecting endometritis or there repeated implantation failure or you are suspecting TB and you want the biopsy material to be submitted for TB culture or PCR based tests for TB because of repeated implantation failure, or you want to see the presence of natural killer cells in the endometrium for repeated implantation failure, in those circumstances we do it, not otherwise, not as a part of infertility workup. So you would say it is mainly now done in suspected cases of endometritis or suspected cases where you have multiple implantation failures.
Thank you, sir. There is another query from Dr. Seema Advani. She has said that for a small lab, it is not possible for a small lab to do all stain for sperm morphology. So she has a query that is it correct to give only count and mobility grade for semen analysis?
See, unfortunately, sperm morphology is a very important parameter. As I told you, that if the sperm morphology, I showed you case of globosospermia. Your count and motility will be normal, and if you don't report sperm morphology, this patient will go on and on with multiple modalities. Actually, he can never conceive because there are no acrosomes. So these type of defect need morphological evaluation. So it is very difficult to omit it. It forms a very important criteria because that's the only criteria which correlates with the fertilizing potential. Your count and motility are not correlating with fertilizing ability of the sperm. But if your morphological score is very poor, you know that fertilization is not possible. So I would not recommend omitting it. There are smaller instruments which typically cost between 4 to 5 lakh for semen analysis now. There is a larger instrument also for the same which evaluates morphology as per WHO criteria, which costs you about 25 lakhs. So those of you who are not having qualified technician or are not keen to invest so much time in semen examination, they can opt for this kind of instrumentation. The smaller version where you can get a reasonably okay semen report will cost you about 5 to 6 lakh.
Thanks. So Dr. added a
Avinash, now
question
that
regarding.
1 minute. Now, can I just ask a follow-up question on the question that
Yes, ma'am.
Avinash,
Yes.
Dr. Fatke just answered? Avinash, would you recommend that, semen analysis because it is a very important test in, male infertility, should be done only in some specialized labs, or they should be centralized if possible. I know sometimes it is difficult to get patients, because the patient should, sort of go to the lab if it is actually possible. How do you address this problem of the fact that so many sperm counts and motility and so on are being asked for, and people don't have the expertise to do it?
Yeah, absolutely. And today we didn't touch upon many topics. See, for example, I didn't discuss about viscosity or liquefaction time. These are important parameters. We didn't discuss about anti-sperm antibodies so much. Again, an important topic. So ideally, it should be done in selected cases, selected places. So in our lab, though we have so many labs in Bombay, if we want a reliable semen report, we have designated only 3 labs out of 24 where patient can bring semen samples or can physically go for semen analysis, because the rest of the labs I am not sure, even if they are our own, that what kind of report can be generated. But unfortunately, that is because I can control it. I am heading a particular lab, so I can control it, but that is not the case with most. So you will see the normal range of semen. I see many reports is mentioned as 40 to 120 million. The minimum motility mentioned as greater than 70%, and the normal sperms are mentioned as greater than 50%. So once we see such report, we know that this person has never actually, and WHO manual 2020 is available online for everybody. Those of you who were asking for figures and charts also, the manual has many colored pictures for sperm morphology. It's available online. You just Google WHO manual 2020 and the whole folder will open up. So what I am trying to say, it requires specialized training. A simple thing like fructose test. Now, if your volume is low, how to conduct a fructose test? Because you are saying you will require 0.5 ml of semen and 5 ml of Seligmanovs, but you must develop a modified fructose where you will use 0.1 ml of semen and 0.5 ml of Seligmanov, because you cannot write that quantity insufficient for fructose test, because that is what the clinician wants to know. Because once you have said repeatedly that the fructose is negative, he is considering either the patient has absent vas or he has ejaculatory duct obstruction for which there is no treatment. So even if the patient is azoospermic, there is no question of doing a vasoepididymal anastomosis if your semen volume is low or fructose is negative. So ideally, if the pathologist is not understanding the implication of what he is reporting, for example, when you report higher viscosity, what is the difference between liquefaction and viscosity? Viscosity is a physical property, which is a rheological property, and you judge that by pulling a string of semen with a glass rod. And if it is more than 2 centimeter, you say the sample is viscous. Okay. Then how to do counts on sample which is viscous? Liquefaction is a proteolytic enzyme deficiency. So there is an accessory prostatic gland dysfunction which is unable to liquefy the semen. So it's an enzymatic problem. So both are totally different. Now both indicate usually are associated with anti-sperm antibodies, or they are associated with infection in the semen. This I am just telling you. So this gives you an idea that unless the person is properly trained in seminology, just reporting count and motility is not enough. You have to report correct volume, correct viscosity, correct liquefaction time, correct fructose, and correct, suppose I report azoospermia, but I have reported spermatid present. The clinician knows that this is a case of non-obstructive azoospermia. He won't even do a testicular biopsy. So it is that important. If I fail to report it, he is going to do a testicular biopsy because he will suspect that let me rule out obstructive azoospermia. So that's why either you need thorough training and designated lab like Dr. Borges just now outlined, or it is better to undergo some course in IVF clinics or andrology workshop. And the andrology workshops you will not get in pathology conferences. You attend any IVF congress, the pre-congress workshops always have a workshop on seminology. And that's the place to learn it thoroughly, because it's a half a day or 3 hour workshop.
Okay. Mona, there are some other questions.
Yes, yes, ma'am. So Swati Dahe has added her question regarding the male-related age-related syndromes for infertility, and she has told that she has asked if there are any syndromes like Marfan or any other related to increase of the male, I think, infertility at the time of conception.
No, I am not aware of Marfan and the sperm count correlation. So honestly, I will have to look up and answer a question. Unfortunately, I am not aware what happens to sperm count in Marfan syndrome. But the very fact I am not aware, it's not a common association. It's not a common association. So I don't think Marfans are infertile. But I am not sure about it. I will have to refer.
Yes, Asana Sahititi, she has asked if there is any relation of age and anti-Mullerian hormone values, and if we can be sure of the ovarian health if AMH values fall under the normal range.
Yeah, see, of course, as you age, the AMH values drop. So when you are menopausal, the AMH value will be very low, 0.2, 0.3, 0.4. The problem comes that at the age of 35, if you have a AMH value of 1.5, which is subfertile, then what do you do? Then in those cases, most of the ladies are now working. They are getting married at 30, then they have career options. So they will try for pregnancy at 33. So by the time they come to IVF clinic, their AMH is on the lower side. So earlier they would try for IUI multiple cycles, or they will take 3 years for natural coitus, and at 36 will go to IVF clinic. But now because of AMH, what happens, we know that the ovarian reserve is low. So even if they don't want to do IVF, the least they can do is collect their eggs and store them for future times, so that there is egg retrieval which they do if the AMH values are low. So as you age, the ovarian reserve deteriorate. Each lady is born with a typical number of follicles which are not multiplying. They cannot be regenerated. Suppose I produce by hyperstimulation 10 follicles in a given person. A time will come that beyond certain level of cycles, I am unable to produce that many follicles per cycle because the ovarian reserve is getting exhausted. So each one of the person is born with particular level of number of follicles, and that is the ovarian reserve which is predicted with AMH. Now, you will see that whether it is absolutely accurate, it is not, because we have seen patients with 4 AMH also not responding well in IVF cycle, and patient with 1.5 AMH responding well in IMH cycle. But by and large, I would say there is at least 75 to 85% correlation between AMH values and the ovarian reserve and the way they respond to IVF stimulation protocols.
Thank you, sir. And one more additional question regarding AMH about the day when the AMH level should be estimated.
AMH has no particular day. You can do it on any day of the cycle. The rest of the hormones, I said, you have to wait for periods to happen, and you have to time it between third or fifth day of the period. For AMH, there is no such restriction because it is not related to your ovulation time. You can do it on any day of the cycle. It doesn't require fasting.
Okay. So there is another question from Dr. Mangla. If there is any association of infertility to testicular tumors.
Yes, in cases of undescended testes mainly. You have inguinal testes, they're exposed to, usually these patients will present as cases of azoospermia, and you do a biopsy, and even if the testis is drawn in the scrotum, many a times the spermatogenesis is severely affected. And these are prone because of the exposure of abdominal heat. You remember one thing, that the spermatogenesis is very sensitive to heat. So if anybody is, say, riding a bicycle or taking very hot water bath, there is significant drop in the sperm count. A varicocele is causing drop in sperm count not only by not draining the impure blood away from testes, but by raising the testicular temperature. So, in a nutshell, these are the issues associated with undescended testes or poorly descended testes. There is a increased incidence of this thing. Apart from that, in oligospermic individuals, there is no increased incidence of testicular cancer vis-a-vis those with normal sperm count.
So, Dr. Akansha Folkmar has asked for the reasons for presence of red blood cells in semen analysis.
So usually it can happen even in normal patients, but the commonest causes are, it shows inflammation in the seminal vesicle, isn't it? The commonest cause of inflammation in our country is, of course, TB. So TB is the most common cause of hemospermia, but many a times uh, multiple ejaculates can cause hemospermia, and we have to tell the patient not to have intercourse or relations for a couple of weeks to give ejaculatory rest to seminal vesicle, because they get inflamed by multiple ejaculates also. So multiple ejaculates, tuberculosis, or any type of inflammation, infection in the seminal vesicle will cause what is known as hemospermia. So we'll get actually semen which is frankly mixed with blood. It's very frightening. And the patient think it is related to prostatic cancer. It has nothing to do with prostatic cancer.
Thank you, sir. Another question from Dr. Digvijay. He has asked, how common is retrograde ejaculation responsible for infertility?
Fairly common. Fairly common. So what we do in these cases, we alkalinize, we give the patient soda bicarb orally. We ask them to ejaculate. Naturally, the ejaculate is retrograde. So he is ejaculating backwards in the bladder. So nothing comes out from the front. So then we will tell him to pass that urine into a alkalinized media. So HAM-F10, the media which is used for IVF, we will give him that media to collect his urine after the sensation of ejaculate has happened. We have already alkalinized the urine by giving him soda bicarb. So we will get live motile sperms from his urine, immediately centrifuge them and use it for either IVF or IUI. And many pregnancies are achieved like that. So not so uncommon.
Another question from Dr. Tulsi. She has asked again regarding the endometrial biopsy, if there is about the best time to do if we have to do the endometrial biopsy.
Now we don't do anything like premenstrual endometrial biopsy. So that was to assess. See, there was, every lady was subjected to DNC and premenstrual endometrial biopsy. Those days are over. Nobody does DNC also. Nobody does premenstrual endometrial biopsy. So barring implantation failure, suspected cases of endometritis, or on your ultrasound scan, you are seeing very shaggy outline of the endometrial cavity, or you are seeing a polyp, in those cases you may do an endometrial biopsy irrespective of the day, because we are not doing it for timing of ovulation anymore. So there is no particular day. Only vascularity, you don't want to do it during menses, so you will wait
Avinash,
typically
you have got muted.
post-menstrually.
Okay, now we can hear you. Yeah, I'm glad that you have made this, said it twice, Avinash, that now nobody dates the endometrium, right? This dating of the endometrium is a very old issue, and I think that it is still being taught in a number of medical colleges. It's okay to teach how the endometrium looks like in the you know in the early proliferative phase and in the late proliferative phase, but it has very little clinical significance in today's world, because everybody gets an ultrasound, and that tells you a lot more about what's going on in the ovary. And we're really not interested so much in what's going on in the endometrium. The ultrasound also picks up the, the thickness of the endometrium and can tell you much more than, and interfering with an endometrium in a patient who is undergoing infertility is never a good idea. I think you will agree with me, Avinash, on
Yeah,
that
absolutely. So
account.
that's why I said nobody does that DNC and premenstrual endometrial biopsy anymore.
But it is a very common thing that people are still teaching in medical colleges, and for all I know, they probably ask it as a question in an exam. I think that's really quite obsolete now. Okay, there was one question. I don't know if you want to address it, Avinash, and that's about medical legal issues in semen analysis. Are there any medical legal issues?
Yeah, medically, only if the patient is bringing sample from home, then whether it is his sample is a issue. So many a times where the commonest situation where I face problem is cases of divorce or cases where the lady is saying that the man is unable to consummate marriage and he has a semen report to back up. The thing is they confuse impotency with infertility. A person can be impotent but can produce absolutely normal ejaculate, and person can be azoospermic but otherwise absolutely potent, but the courts and the lady doesn't know it. So many a times in these impotency battles they produce some semen analysis report and call us as witness from either side, either to collaborate or to dispute whatever is happening, and you have to explain to the judge that there is no correlation between semen analysis count and the ability to have erection. These two are entirely different things.
Mona, is there anything else? I see here there is a
Yes, ma'am.
question.
There are few
How to
questions.
process semen when liquefaction is prolonged? Time is prolonged.
Yeah, so if the liquefaction time is prolonged, you have two, three choices. One is you can ask the patient, first of all, remember one thing, these are in vitro observations. This is not what is happening physiologically. So the ideal answer is, but nowadays we don't follow it, but what should be done ideally is to do a postcoital test. Ask the patient's wife to come after intercourse, and if there are enough number of sperms in the cervix at the internal os level, you know that this liquefaction didn't matter because her cervical mucus had proteolytic enzymes to liquefy this semen. But because we don't want to do that, we use artificial means. So artificial means for liquefaction is to add proteolytic enzyme. So you can add chymotrypsin or trypsin so that it makes it liquefied. But that is for the purpose of counting. It doesn't apply to a vivo situation. His liquefaction delay may not have anything to do with his infertility if the postcoital test is normal.
Thank you. So another question from Dr. Subira. She has asked about the number of WBCs that should be considered normal for a single high power field.
Pardon?
Number of white blood cells that should be considered normal for a single
See,
high power field.
I will tell you approximately. When you say less than 1 million, then your normal count is around 20 to 30 million. So if your patient's count, let's say, is 40 million, then every 40 sperm heads, you should see only 1%. If your patient's count is 10 million, then you should see in that proportion. So your percentage is less than 1 million per ml. So if the count is 10 million, then every 10 sperms can show 1% is allowed. If it is count is just 40 million, because that number of percentage of pus cell, it doesn't change with the count, it is fixed, because it is mainly seminal vesicular secretion which is causing pus cells, and it is nothing to do with the sperm content in the semen. So for our purpose to calculate, if it's a 40 million ka sperm count ka patient, you count one pus cell per 40 sperm is allowed, anything which is more than say 2 or 3 cell per 40 sperms, then the count is going to be 2 or 3 million, which is higher than recommended. I hope I have answered.
Yes, yes,
I
sir.
think you've answered a lot of questions, Avinash, and obviously you have engendered a lot of interest in those who were attending your lecture, because usually the questions don't go on for so.
No, I am happy to answer because
Yes.
this is a clinical topic. It's not pure pathology.
No, in fact, I think, Avinash, in general, most pathology should have a clinical connotation. Otherwise, it doesn't make sense. I mean, we're not talking to other pathologists. We're really talking to, our reports go to clinicians and to patients. And on the basis of that, a lot of decisions, clinical decisions are taken. And I think I'm glad that you put your whole lecture into a clinical context, which is as it should be. So I thank you very much for having taken the time in your really very busy schedule to come and talk to our young audience over here. I know that there must be a lot of people who are actually practicing pathologists who were very curious about how to do a better job of whatever they are doing at present. And I think that you have made it very clear that people can do much better than what they are doing. And you have given very good suggestions that if somebody is wanting to do this, how they can find, the either the books or the way in which they can attend these symposia and seminars, etc., to upgrade their knowledge. And you've got a lot of thanks. That if you're looking at the chat box, it says thank you, thank you, thank you, and there are lots of claps. So I add my own thanks to that of the audience. Thank you very much, Avinash. I learned a lot, and just to tell the audience as to why AMH does not vary with the time in the cycle, because AMH is actually I correct me if I'm wrong because I haven't looked it up, is being formed by the granulosa cells, and
Yes.
that is what is it doesn't really matter if you've got granulosa cells over there, and which we do in our it tells you about the ovarian reserve, how many ova are still there, which could potentially develop into follicles and mature into ova that can be fertilized. So I think that that's something that we are very grateful for, Avinash, and thank you, Mona, thank you, Talal, for having done a very good job of moderating this symposium. And as always,